Good afternoon, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. That is on a very important topic: why January feels hard, biological, psychological, and social factors. Brew Monday. And as we know that this topic is very much important, and we need someone who is expert. So, without any further delay, I would like to invite our guest speaker, none other than Professor Dr. Ranjan Bhattacharya, sir. And let me share some of the achievement of sir. Sir has done MD, DNP in psychiatry and MNAMS and professor at West Bengal Medical Education Services, and his area of interest is addiction, psychiatry, sexual medicine, and child and adolescent psychiatry. And sir are associated with lots of membership and fellowship. Sir, IMA Dr. R.N. Murthy National Award in Psychiatry from 1920 to 2020 and 2020 to 2021, and winner of BPSSJ, BPA, and IJCM Award, and organization position Honorary Secretary East Zone, Indian Psychiatrist, and Society of Honorary General, Joint Secretary IMA Bengal, Editor-elect JIMA Editor, and he has also been American Psychiatrist Association member, IAPA, and Distinguished Fellow of IAPA. And sir is also a member of Indian Psychiatrist Society, Indian Association of Private Psychiatry, and Indian Association of Geriatric Mental Health, and Indian Association of Biological Psychiatry. So, without any further delay, I would like to invite sir and hand over this webinar to sir. Sir, the stage is yours. You can proceed from here. Over to you, sir.
Thank you, Faraj, for this kind and generous introduction. Thank you, the team IGCP, for inviting me in this Med Talks. So I had the privilege and honor of having this talk before as well. So it is a great opportunity, and I'd like to start by saying the a very happy New Year to all our guests who have been joined here today. And today know that we are in the month of the January, and if we go with the saying of the poet that if winter comes, can spring be far behind? So this is a winter month, and we know there are lots of issues comes up, especially during winter months, and this seasonal variation may affect your psychological health as well. So mental health and psychological health being affected, we call it as a winter blue, January depression, so on and so forth. But there is a specific entity, we call it a seasonal affective disorder, which comes during this winter month because the mood symptoms are directly related with the exposure of sunlight. So my topic will be on the beyond the winter blues, the clinical reality of the seasonal patterns. So as we all know that the blues are being called when there is a our mind will be very gloomy, but that doesn't necessarily mean that you are depressed. So blues are very common, we can come across in our obstetric wards that people used to suffer from the postnatal blues. Just after the delivery, the mothers are getting having some low feeling, but when it becomes a pathological entity, then we call it as a postpartum depression. Similarly here, the seasonal affective disorder. So the my talk will be a spectrum of journey. What is the bio-psycho-social model by the Engelman who first termed the coin? Because our illnesses are impacted with lots of factors like genetic factor, whether we'll be suffering from the type 2 diabetes at the age of 40 years, hypertension at the age of 50 years, stroke at the age of 60 years, probably written in our mother's womb. So similarly, the genetic factor, epigenetic factor, social factor, as well as the environmental factors comes in play while having any sort of the mental disorder. So when it comes, it impacts us heavily. So my point of discussion will be about the what are the clinical framework, the epidemiological data, what we are having with the seasonal blue, the US data, Indian data, and we have to be with the various symptomology, and this symptomatology are very much linked with the, as we know that there are terms the signs and symptoms. When you cluster those symptoms by doing some statistical framework, there comes a diagnostic criteria, because we do not have any schizobacilli or meningococcus to diagnose the case of schizophrenia or bipolar affective disorder. We have this stringent entity the biological makeup, etiology, vulnerability, and the gender difference of the seasonal affective disorder and the winter blues or the January depression, therapeutic pathway, and emerging research is what having, because researches are going on and these researches are very important for the clinician to know. So seasonal specificity is very common in our modern psychiatry. So seasonal affective disorder comes as a specifier when we diagnose the DSM-5, the Diagnostic and Statistical Manual of the fifth version by the American Psychiatric Association, and the ICD-11, that is the International Classificatory System of Diseases developed by the World Health Organization. The seasonal affective disorder actually comes in DSM as a specifier because some disease got flare up in this situation, especially the depression. Some blues are very common as mentioned, but what is the biology? Where there are lots of factor, stress factor, sunlight exposure factor, the melatonin. We know that the melatonin is being secreted from the third brain, we known as pineal gland, and the DLMO, that is the dim light melatonin onset, which starts at 8 p.m. and peaks at 11 p.m. It is a key regulatory neurohormone that is very important in the this symptomatology related with the seasonal affective disorder. When you have the jet lag, when we have the night shift work, we know that the melatonin is the key regulator. When we have an east to west travel or west to east travel, if it crosses the two time zone, it is very difficult for the sleep biology, the chronobiology to get adopted. So seasonal specifier in modern psychiatry comes with the depression, it comes with the bipolar affective disorder. It also has a specific relationship with the other disorder, including schizophrenia, substance use disorder, as well as the various symptomatology that we find the child and adolescent. Some symptoms are flare up and some symptoms are actually get reduced. So these are the area, because we know that the lassitude is extremely important. Those who live in the far north or the far south zone, they are getting the less amount of the sunlight exposure, and that is the key concept for having the seasonal affective disorder, because the daytime is very short, the night time is very long, and the sunlight exposure is less. So when the sunlight exposure less, the vitamin D3 synthesis will be less, as well as the melatonin will not get properly secreted in time and cannot maintain the chronobiology. And vitamin D3, melatonin being the precursor of the serotonin, and serotonin on 5-hydroxytryptamine is the key for the mood symptom. We call it the happy hormone, though it is not hormone. Serotonin is being known as happy hormone, dopamine is known as the pleasure hormone. So these are the key concept of the chronobiology and the neurobiology and the neurotransmitter involved. So there are DSM 5 tier framework, and this has been are very important for our day-to-day perspective for diagnostic classification, as the SAD is called as a specifier with seasonal pattern. And for major depression and bipolar disorder, we know that the bipolar disorder 1 and bipolar disorder type 2 are there. In the bipolar 2 disorder, the depressive episode has to be there. Without even having a depressive episode, we cannot diagnose a case of bipolar 2 disorder. In bipolar 1, we can have a manic or hypomanic episode with or without depressive episode. Second point is the clinical requirement. The episode must demonstrate a regular temporal relationship. And interestingly, you'll be amazed to know if you just ask me to know the key 2 points. First is the seasonal affective disorder is more common in women, thumping majority. Women are getting more suffered from this SAD or seasonal affective disorder, winter blues. And second point is that if an individual is suffering from SAD, seasonal affective disorder, it will come at the same time of the season and will go away at the same time. So such a the association or temporal relationship is there of the connectivity. If it comes in the month of early days of the December, it will definitely go away in the middle of the June. So this pattern will follow every now and then. And the severity and function is very important, because symptoms must be distressing enough. So any condition has to be, if it has to be a case of disorder. So disease and disorder are different concept. Within the in our mental and behavioral disorder, we call it disorders, because it is a group of symptoms, and their severity and functionality will affect the day-to-day functioning, when our social life, occupational life, educational life will get jeopardized or affected. So Coming to the prevalence and trends, if we go with the Western counterpart, the US adult prevalence of the seasonal affective disease is 5%. So, estimated percentage in total US population. So, 1 out of 20 Americans are suffering from the seasonal affective disorder. The winter variant prevalence is the most common form because summer prevalence is also there, but you can see the winter prevalence is around 3% and the summer variant prevalence is only 0.1% rarer. As we know, the in depression we commonly have reduced sleep, reduced appetite, but in case of atypical depression there will be increased sleep and increased appetite. We call it the vegetative symptom: sleep, appetite, bladder, bowel, sexual function. These five groups comes with the biological function and vegetative function. This will get affected more. Now, if we go with the demographic variant distribution has already been mentioned, the clear cut, the thumping majority is the female presentation. 80% of the group of individual who are suffering from the winter blue, January depression or seasonal affective disorder are women, and the summer onset and the general population onset has been can you can be vis-a-vis demographic category can be clearly shown. But again, I would like to mention the SAD, the seasonal affective disorder, is a very common entity because we know when it becomes blue, there's a less chance of having suicide. But when it becomes disorder, seasonal affective disorder, there is a more chance of attempting suicide. So if the clinician cannot diagnose this as a seasonal affective disorder, the treatment will get delayed. And apart from the traditional pharmacotherapy and the cognitive behavioral therapy, we also had a specific type of therapy. I'll come to that part in later. So why your energy dips in water? There are, as mentioned already, the neurobiological theory. Everything is neurobiology. So depression is related to the serotonin, and serotonin is being secreted for the midline raphe nuclei. As with dopamine is a pleasure hormone, as we mentioned, it is being secreted from the ventral tegmental area of the midbrain. It goes to the nucleus accumbens and then goes again another kick to the prefrontal cortex. And dopamine circuit is a reward circuit. Also, the criteria for depression, the major criteria, one of the two has to be present. First is the low mood, and second is the lack of interest in pleasurable activity or anhedonia. Hedon is the Greek god of pleasure. If you have the lack of pleasure, so again mind that low mood is attributed with serotonin, but lack of interest or anhedonia is primarily attributed because of dopamine. So serotonin is the not the single monotransmitter that is responsible for the depression or the winter blues or the seasonal affective disorder. Dopamine has also played a role. And weather driven sedentary lifestyle, we know that in winter we don't cannot get up early up in the morning, and we cannot have our exercises. We get delayed for everything because the daytime is short. So we have to change our lifestyle, and sedentary lifestyle will lead to more problem. As we all know that exercise is generating 30 minutes per day exercise will release the endorphin, and endorphin will give you also a kick, the pleasure or feel good feeling. But when the endorphin will not get released, there is a more chance that the synchronization with the melatonin, serotonin, vitamin D3 will all come into play. The holiday stress are more because it has to be a more holiday period, and you are not getting got an opportunity to meet with your classmate or college mates. The school or colleges are absolutely at that time shut down, or in the early part the examination, the board examinations are there. Social isolation, you cannot mix up with the people because you have to keep yourself confined in the room in the most of the time of the day in the winter. Colder temperature will lead to more just aggravate the problem. The hypothermia will come into play, and hypothermia will lead to the reduction of the BMR, and that is generate more and more problem. It is very difficult to maintain the outside temperature with your coat temperature. The struggle is on. Disrupted sleep pattern, we all know that the common time, an ideally individual should have a 7 hour sleep. 6 to 8 hours is the spectrum. Anybody who's sleeping less than 4 hours is called short sleeper. More than 9 hours per day called as a long sleeper. So adequate duration of the sleep is mandatory, and preferably should be 11 p.m. to 6 a.m. Today we are encounter the two common type of phases of sleep problem. One is called delayed sleep phase syndrome, where they late to bed and late to rise youngsters. the Gen Z, Gen Alpha, they are doing that. So we know that the Gen Z is a very big. They are having being. We just call as the thing that is I'm zoning out. So zoning out phenomenon is very common among them, and the winter blues, they're more vulnerable. The adolescent population, the 10 to 19 years, as described by the World Health Organization, is more vulnerable because they are having DSPs, late to bed and late to rise, and this will generate the more problems. Contrary, the elder people, they are early to bed and early to rise. They are being called as the larks. So larks versus owls, the DSPs, it has been proven that the larks are more professionally successful than the owls. And the problem with the elderly population is that they are sleeping at say 9:30 or 10 p.m., but they are getting awakened in the midnight, say around 3 and 4 a.m. And after that, the sleep will not come. So this will lead to the more problem, because the early morning depression, it has a very common harbinger of attempted suicide, and the suicide is more common those who are having the lack of sleep. And winter, the since the depression is more common, sleep is getting affected, the individual vulnerability of the suicide is also common. Again, winter is a period when the pain symptom will increase, who are suffering from the rheumatological connective tissue disorder or problems related to the degenerative osteoarthritis, low back pain, neck pain, cervical lumbar spondylosis will be more. Winter, there's a chance of blood stasis, and that will lead to the more chance of the coronary artery disease. And winter is the time when the elderly population are more prone to have the respiratory distress, especially we are suffering from the COPD and asthma. So adding this up, the depression will be more. So winter is not a very good time as far as the health is concerned, but there are lots of fruits, lots of vegetables, lots of winter vacations are options are there. So exposure to sunlight is the key. And when it comes to the winter onset, the classic presentation is the marked by the hypersomnia and excessive sleeping and persistent fatigue. Dietary changes, the characteristic carbohydrate craving, sweet cravings are more, increased appetite, weight gain is more compounded by the lack of exercise, and temporal trigger like the symptoms typically emerge in late fall and reach a full remission by spring or summer. So when it comes to the somatic divergence, if we come in with the winter onset SAD 3% versus summer onset SAD 1%, the sleep pattern hypersomnia versus insomnia in summer onset, appetite increased or craving more in winter but reduced in summer onset, weight trend gain in the winter and less in the summer SAD version. The weight loss is more commonly seen in the summer version of the seasonal affective disorder. Weight trend is the, as mentioned, being gaining in the winter onset. Mood state, lethargy, heaviness are more common in winter onset seasonal affective disorder, and agitation, anxiety, hyperthermic temperament are more common in the summer onset SAD. The summer onset SAD is a rare variant. The intense light variant here the understand the unique challenges of the heat triggered depression episode, and the environmental stressors are there likely to increase extreme heat, the high humidity, and the prolonged and intense sunlight exposure with the sweating, loss of electrolytes, behavioral manifestation like the restlessness, anxiety, and in the severe cases, there will be violent and aggressive behavior. You may know that the bipolar disorder patient who are suffering from the bipolar affective disorder, the manic and hypomanic episode comes more commonly in the summer time. The hyperthymic temperament, the over elated joyous phase, and that is preceded by the decreased need for sleep, not the decreased sleep. There's a decreased need for sleep. I don't require any sleep, and that will eventually trigger up the manic or hypomanic episode. Secondly, thirdly, the biological factor linked to the very important the pollen inhalation and releasing of the biological compounded and connected with the depression. So these all compounding with the phenomenon. Next is the biological drivers of the seasonality. The circadian rhythm, as we already mentioned, the chronobiology. The circadian rhythm is extremely important, and if this circadian not maintained by the pineal gland, and the secretion of the melatonin is the key, the serotonin drop and melatonin surge. As we all know, the increased winter darkness triggers excess melatonin, as the darkness is when the darkness will be there, the nyctophilia. So in that phase, the melatonin will get more secreted, and circadian is an internal clock which is disrupted by the reduced exposure of the sunlight in winter, leading to the mood shifts. And serotonin drop, there is a decreased level of the serotonin, and this decreased light exposure related to the decreased serotonin, and these neurotransmitters is affecting mood, as already been discussed. Now, path to clinical trials, initial clinical examination, comprehensive evaluation is required, and to rule out the physical health conditions, whether there are any comorbidity, whether the person is suffering from type 2 diabetes mellitus, hypertension, dyslipidemia, any other hormonal disorder which can disrupt this circadian rhythm pattern, and the temporalness is the onset of the depressive episode or blues and the ending up of the blues, and confirming mood episodes align with the specific time frame for at least 2 years is mandatory. So 1 year observation we cannot call as winter blue, winter depression, SAD. At least 2 years has to be there. Differential screening, differentiating from bipolar disorder and adjustment disorder with seasonal stressor. And finally, DSM-5 tier applying with the seasonal pattern specifier if criteria are not being met. Like coming to the 2 year diagnostic standard, there are pattern verification, remission criteria, and the prevalence balance. The pattern is the time of onset and temporal relationship, at least for the two consecutive years. For example, starting in the month of the middle November and ending up in the middle of the January. Episodes must follow a pattern of full remission. There should not be any symptoms of depression left after this period is over. And prevalence balance, seasonal episodes must substantially outnumber any non seasonal episodes over the patient's lifetime. So these are the criteria. And coming to the therapy in the left hand side, you can see the major instrument that is being used, that is called phototherapy. And the phototherapy is nothing but a bright white illuminating light of 10,000 lux and 20 times more than the normal illuminating phase. And this will generate the more release of the melatonin, serotonin, and this will reduce the symptoms of the depressive symptoms of the seasonal affective disorder. And at least 20 to 30 sessions of the bright light therapy is required in a span of say 60 days. On every alternate day or in the almost every day we have to give during the peak phase of the seasonal affective disorder. Daily exposure in minutes typically, the early morning it has been given, and the clinical effectiveness of the bright light therapy is as high as 85%. But there are certain precautions. If you are suffering from the type 2 diabetes mellitus, you have to check the your retina, whether his retina is being involved with the retinal detachment or anything is there. So bright light therapy is prohibited for them. We give the dark glass for them to for protection of the retina. All the other body parts are being exposed, but not the eye. Second is the patient who are having certain anti-inflammatory, non-steroidal anti-inflammatory drugs or certain antibiotics which are photosensitive. We should be very careful while giving the bright light therapy to them. And finally, we have to check that whether in a skin condition that can aggravate this can be a contraindication of the bright light therapy. But coming to the positive aspect of the bright light therapy, yes, it is very effective. And apart from the pharmacotherapy, it's a very a good therapeutic armamentarium we are having nowadays. Also, there are SSRI. The five SSRIs are there. There is fluoxetine, fluvoxamine, sertraline, escitalopram, and paroxetine. It works very well. Some group of drugs, that is SNRI, that is serotonergic norepinephrine reuptake inhibitor, like venlafaxine. This is a very important molecule that we can prescribe. So first intervention should be phototherapy, and phototherapy are given to those patients who have been the suffering from SAD. So not required for the winter blues in general because it goes away in normal way. But the mechanism is that the morning exposure of the sun, this phototherapy occurs in the first hour of waking to signal the brain biological clock. You will remain very alert. The retinal reception, light enters to the eyes rhodopsin, stimulating the retina to send the signals to the hypothalamus, and hypothalamus is down regulating the entire HP axis, neurochemical reset, the suppression, the excess melatonin and boost serotonin production. The psychotherapy for seasonal pattern, the behavioral activation technique, the behavioral activation by doing the cognitive behavior therapy, where you are being surrounded with the three negatives: negative about self, negative about environment, negative about future, that is worthlessness, helplessness, and hopelessness. That makes classical cognitive triad for depression. By behavioral activation system, a routine is being prepared and how to activate your day by day behavior one by other, the chain reaction, so that you get activated throughout the day and doing something. All work and no play makes Jack a dull buzz. So we need to take some break from our regular hectic office schedule. Work from home is a very important risk factor for getting affected for SAD. At least 3 days a week you have to go to your office to mix up with your colleagues. And cognitive restructuring, as we already been mentioned, the cognition is the very important. The classical cognition, connection and affect, these are the three major way we treat the by virtue of the CBT. And the coping strategies, there is the developing individual planning and how to manage the symptoms before they come up. We call the primordial prevention. Before the uh, before the startup of the actual disease, certain precautionary measures are being taken. Pharmacological measures, I already mentioned, SSRIs are very effective drug. It has been proven by the various double-blind, randomized, placebo-controlled, multi-center trials. SSRIs are very powerful drugs. The preventive dosing, the medications like the bupropion are often started before typical symptom, and bupropion is an NDRI group of drug, norepinephrine, dopamine reactive inhibitor. It increases both norepinephrine and dopamine by preventing their reuptake. So more amount of the norepinephrine and dopamine are available in the synaptic cleft. So presynaptically, it will act more faster. And interactive supplements, certain vitamin D3 supplements, it works in a wonder. We are suffering with the 3Ds, 3D effect, I call it. 1D is the diabetes. India is now the world capital of the diabetes. Second is the depression. In National Mental Health Survey, it has been proven that one in every seventh Indian is suffering from some sort of mental illnesses, and depression by large is most commonest type of the illnesses of mankind nowadays. Comprehensive lifestyle analysis by outdoor exposure, by consistent routine, meeting a certain routine, physical activity, generating endorphin, and controlling the temperature. For summer acidity, staying cool and avoiding extreme heat and humidity. The outdoor exposure, like the spending time outside, even on the cloudy days, to maximize the natural exposure of the sunlight. The constant routine should be there, because I have come across with the Gen Z who have born 1997 to 2012. They are waking up 6 a.m. in the morning while attending the classes. But on Sundays, they are waking up at 10 a.m. Similarly, those 5 days a week we are doing in the office job, waking up very early in the morning. But on Saturday, Sunday, we're waking up at 11 a.m. That should not be done. So SAD is a type of depression that is related to the change in season, and SAD, that is a seasonal affective disorder that will make yourself sad. Sad will make you sad, and begins and ends at about every same time in the year. Climate change and mental illness has a very direct relationship. In the 2023 clinical study, it has been found that disruption in the sunlight and the circadian rhythm during the seasonal shifts almost interfere with the neurochemistry. And the person who are having the night shift worker, the watchman, the ATM watchman, and the hospital staffs who have to wake up in the night, they are more vulnerable for suffering from the seasonal affective disorder. So evaluation of the SAD research, the historical anecdotal findings, initial observation, followed by DSM 5-tier specifier, where the major depressive disorder with seasonal pattern has been introduced. In 23-24, the neurochemical focus had been shifted, and advanced studies on serotonin and the circadian disruption mechanism are on way. And what is emerging? The exploring virtual reality for increasing the artificial natural light exposure, digital and VR integration. But we remember that when you affect the seasonal bright light therapy, that we have to protect the UV light exposure. The natural fluorescent white light is more effective. So clinical implication and best practice with early intervention, stigma reduction. Let's talk with depression was one of the most favorite tagline of the when we encounter and we used to establish over a couple of years with the when we come across the World Mental Health Day, and continuous research is there. Talking with the people will make yourself more engaged, and if you have the good peer group and supporting staff, we may not suffer from the depression or ACD, because we are keeping ourselves engaged with some sort of activity which is satisfying. So my take home message is that building a seasonally resilient society is the call for the day. We have to be resilient. We have come across the COVID almost 6 years back. We have suffered from COVID. The resilience literally means that the ability to bounce back. When you'll be in the adverse situation, you might get back somewhere 120-degree back, but you have to bounce back when the situation will come back. So day in and day night, the testing time will go. So black phase is not there for the lifetime. There'll be always the light at the end of the tunnel. So building a seasonally resilient society through empathy, clinical rigor, proactive care, and we can mitigate the impact of the seasonal mood disorder. So I'd end up here. Thank you again, IGCP, for giving me this opportunity, and thank you to all the listeners who have listened this webinar with your passion and utmost dedication. Thank you.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice too. So we have received some questions, sir. With all your permission, shall we take these questions?
Please, please.
First question is, sir, what role does social withdrawal or the post-holiday letdown play in the psychological shift from the high energy festivities of December to the routine of January, sir? What's your point of view on that?
So when you are moving in a speed of 140 kilometer per hour, then suddenly stop your car. Then again you have to come out, drive again 3 days later. If you just miss a train, just recall if you miss a super fast train, so again you have to chase the train if you just stop there. So there should be a routine, because taking 2 or 3 days leave for the festive purpose, especially we have seen in the corporate life, it is not getting. But some cases where the people try works very hectic schedules in the throughout the consecutive months, they are looking for a break, and when this break comes, they completely gets aloof for 3 or 4 days. You need to take break every day, not after a hectic schedule of 3 months. So these 2 or 3 days break will jeopardize the normal phenomenon. So always maintain a healthy routine and lifestyle. You should stick to the routine. You should stick to the lifestyle, whether it is a working day or whether it is a holiday.
Thank you so much, sir, for sharing your expertise on that question. We have another question, sir. How do financial stressor and the pressure of New Year resolutions contribute to the spike of cortisol level and perceived mental fatigue during this month, sir?
A very important question, because in the year ending phase, and when we are starting from the Christmas day 25th December to 1st January, there's a long week. So this is a week for celebration. People do lots of relaxation technique, but whether while doing with the wrong coping mechanism, like taking the substance of abuse, going with the alcohol, going for a rape party, and again for the 7 consecutive days, the festive seasons, we engage ourselves in heightened state of mind, not getting able to relax. Even the journey, even the long vacation, after vacation you may feel fresh, but the vacation journey and the vacation stress will also encounter. So stress will lead to the increased levels of cortisol, and cortisol will lead to the neuronal apoptosis, and neural apoptosis means the programmed neuronal death, and HPA axis will lead to the activating the pituitary is known as a master gland. So from anterior pituitary, all the activating the hormones will secreted, and most important one is the adrenaline. Adrenaline is being secreted from the adrenal gland. Adrenal gland, we call it the suprarenal gland. The renal means kidney, suprarenal means the just above the kidney. From the cortex we get the steroids, and from medulla we get epinephrine or adrenaline. Adrenaline is a flight or fright hormone, but too much excess of adrenaline being secreted in this phase of life is very bad, and this will lead to the vicious cycle and will lead to the more neuronal apoptosis.
Thank you so much, sir, for answering this question, sir. I hope it will be very much helpful to all the viewers, sir, and you have done justice to this topic. I can't see one comment from Dr. Subramaniam. He has written very important topic. Thanks for discussing. And like
Thanks,
as
Dr.
we know that, sir,
Subramanian.
mental health is a problem. Yes, sir. And like, as we know that mental health is a problem, sir, which is not seen. It's not a physical damage. It is an internal damage. And like it's in. I hope that through this session, it will be very much helpful to all the participants who have joined. Sir, as there is no more questions, sir, with all your permission, shall we conclude this webinar for today?
Thank you so much, Faraj. Thank you, Med Talks. Thank you, Team IGCP, for
Welcome,
giving
sir.
me this opportunity, and thank you to all listeners. Bye bye.
Yes, sir. It was great honor to host you, sir, and we would like to see you in future also with different topic. Till then, take care of yourself. Thank you, sir.
Sure. Thank you.